it's Dr. Perumal here. I'm a cataract, glaucoma, and pterygium surgeon based at Revision, Auckland, and also in Auckland District Health Board. So today I'm going to speak to you on what do you need to know about glaucoma. And this talk is mainly targeted towards general practitioners, medical students, optometrists, and optometry students, uh, because this condition is so important to know and manage appropriately. So let's begin with talking a little bit about some stats about glaucoma. Glaucoma is one of the leading causes of preventable blindness in New Zealand and other developed countries. It affects approximately 65 million people worldwide. Approximately 2% of patients over the age of 40 have glaucoma, and that increases to 10% in patients over the age of 80. Half of the people who have glaucoma don't even know that they have the condition. And the condition is best managed when you pick it up early. So that is the whole intention of this talk. So you know how to advise your patients about glaucoma and where your role comes into increasing the education awareness about this condition. So I've got a little diagram here, a video of explaining the condition. So within the eye, there's fluid produced in the ciliary body, and that fluid leaves out of the eye through the drainage angle. Now, the balance of the fluid production and the fluid outflow forms intraocular pressure, also called IOP. If you have not enough fluid draining out of the eye, or too much production of fluid, then the pressure within the eye goes up. And that elevation in pressure causes damage to the nerve within the eye, which is called the optic nerve, and this forms a group of conditions which is called glaucoma. When I say a group of conditions, there is a spectrum of how we diagnose or classify patients with glaucoma. On one end of the scale, you have ocular hypertension, which is where the pressure is elevated, but there isn't any damage to the nerve within the eye. And then you have nerve damage, which is either classified as primary or a secondary cause. And lastly, based on the angle configuration, whether someone has open drainage angles or whether the drainage is shut. Now, the other caveat is that you do have babies who are born with glaucoma, and that is called congenital glaucoma. And the management of that is quite different from what we will talk about today, but the general principles are there. Risk factors for development of glaucoma, but age is definitely one of the bigger risk factors. The risk of a glaucoma goes up with age. As I've mentioned, 2% of patients over the age of 40, 10% in patients over the age of 80. A family history increases your risk by 4 times. So close relatives of patients with glaucoma should be tested from the age of 25. Ethnicity, such as European and Afro-Caribbeans, have a greater risk of open-angle glaucoma. In particular, Afro-Caribbeans tend to have very aggressive forms of glaucoma, and Asian patients tend to have many angle closure glaucoma. Medical history, such as diabetes, increases your risk of secondary glaucoma or neovascular glaucoma. Being short-sighted increases your risk of open-angle glaucoma. Being long-sighted increases your risk of angle closure glaucoma. And other factors which I think are particularly important for GPs to know are the prolonged use of corticosteroids increases your risk of ocular hypertension and also open-angle glaucoma. Eye trauma increases your risk of glaucoma. Certain medications, which I'll discuss later, can also be an issue in patients with narrow drainage angles, and also thin corneas increases your risk of glaucoma. Here's a table of the different medications which can potentiate or incite acute angle closure glaucoma. Of those, the ones which I feel that you need to be aware of are the SSRIs, the tricyclic antidepressants, and also topiramate, which can give rise to angle closure glaucoma. So if you are going to start a patient on these medications, it is prudent to determine what type of glaucoma they have, and if they've had a history of narrow drainage angles, and if they've had laser peripheral iridotomy, then it is usually not a problem. However, if a patient has narrow drainage angles and haven't had laser peripheral iridotomy, as an ophthalmologist, I would be more inclined to do the laser much earlier so the patients can continue or be started on these medications. So it's really prudent to be aware of this association of these different drugs, which can precipitate angle closure in patients with narrow drainage angles. Patients with glaucoma are generally asymptomatic, especially at early stages of the glaucoma, and they may just present with gradual peripheral vision loss. But if I have a patient with glaucoma and they tell me that they're aware of having cloudiness or mistiness in their vision, then I'm actually more worried because those patients typically have quite advanced loss of the peripheral vision in glaucoma, and it's usually at that stage where we're considering surgery. But the one caveat is those patients who present with acute angle closure glaucoma do not think that this is conjunctivitis. And we certainly have seen cases where patients have gone blind because they have been misdiagnosed as having conjunctivitis or having a subarachnoid hemorrhage or having appendectomies. These patients with acute angle closure glaucoma present with severe eye pain, headaches, nausea, vomiting, blurred vision, and seeing halos around lights. And these patients have blurred vision because they have corneal edema, they have red eyes, so that's why they're mistaken as having conjunctivitis. And in some patients, because of their GI symptoms, they think that they're having a GI surgical acute abdomen. So it's crucial that you know those are the patients who present with symptoms. Most patients with glaucoma are picked up because of regular eye screenings, and this is mainly done by the optometrist. The basic assessment here includes a measurement of the intraocular pressure and also the corneal thickness, because the thinner the cornea is, it means that the pressure is actually a lot higher than what we are testing as, and therefore thin corneas are another risk factors of glaucoma. The assessment also involves a very comprehensive assessment of the optic nerves, visual fields, and also OCT. When it comes to assessment of the visual fields, one can look at these diagrams, and what I can tell you is the interpretation of it is going to be based on the degree of blackness or areas that patients can't see during their peripheral vision test. So the blacker the areas, the more severe their loss. And what you see with glaucoma is depending on the site of the disease. So, for example, if the site of damage is here, then that would correlate with the degree of visual impairment in your peripheral vision. So you have a loss in the inferior aspect of retinal nerve fiber layer here, then you have a superior visual field loss. The diagnosis is almost also done retrospectively because we see a loss in the nerve thickness and the function of the nerve. So if you look at this picture here, so this is an appearance of the optic nerve, which over time you can see has become a bit more scalloped, more scalloped and a lot thinner, particularly in the superior and lower aspect of the nerve, and that's consistent with glaucoma. So we have better ways of picking up this diagnosis, particularly with OCTs and better algorithms in the visual fields. And this all forms what's called interventional glaucoma, where we have better ways of picking up glaucoma at an earlier stage. And so as a glaucoma practitioner, we are now intervening much earlier before a patient has profound loss of vision. Interventional glaucoma, then we're now going to talk about management of glaucoma. So the management of glaucoma has largely been based on medications and laser treatment. And in terms of medications, at least in New Zealand, we have different four major categories of glaucoma treatment. You have different forms of laser, which I will discuss shortly, and also surgery, where we have the conventional ways of treating glaucoma, and now the newer versions, which are called minimally invasive glaucoma surgery, which I will discuss in my next presentation. Treatment has mainly been the first line of treatment in glaucoma for many years now, and of which we have different classes of medications which have different potential risk profiles. So your role is to know what are the potential side effects and to communicate this with the glaucoma prescriber. Prostaglandin analogs are the most commonly prescribed drugs, of which latanoprost, Trevor, and Lumigan are the most commonly prescribed. The side effects include red eyes, eyelash overgrowth, and orbitopathy, where they have a sunken eye appearance. Beta blockers, including timoptol, XE, betagan, and timolol, can be associated with asthma, red eyes, impotence, vivid dreams, postural hypertension, depression, heart blocks, and also reduce exercise tolerance. And for this purposes, I generally avoid treating my younger patients and patients who have normal tension glaucoma and poor peripheral perfusion, circulation um, with this drug. Alpha agonists such as iopidine and alpha-GAN, brimonidine, can be associated with conjunctivitis, lethargy, and also dry mouth. Azopt and Trusop can be associated with stinging, blurry vision, bitter taste, and pilocarpine can be associated with headaches. Now, if the patient's on combination medications, then they can have the side effects associated with each one of those agents. And lastly, preservative toxicity can be associated with red eyes, foreign body sensation, and also irritation of the eye. Laser for glaucoma is also now becoming quite important, especially in the realm of interventional glaucoma, which is where we have become much better at diagnosing and picking up glaucoma. And so we prefer to intervene at a much earlier stage prior to developing advanced visual field and glaucoma losses. So selective laser trabeculoplasty, which is shown in this picture over here, is a form of treatment of primary open-angle glaucoma and ocular hypertension. It's done as a day procedure, and what you can see here is laser striking this drainage angle here, and it causes small little bubbles of gas to be formed when we see a reaction. So this is very good at lowering the intraocular pressure by 30%, so equivalent to a prostaglandin analog, and can be done at any stage of glaucoma. It's painless, it's very well tolerated, and patients can even drive home after having the laser procedure done. The second procedure here is laser peripheral iridotomy, and what we're doing is we're creating a hole in the iris, and this is done in a treatment of angle closure glaucoma. And the idea is by creating a hole, it stops fluid from accumulating behind the iris, because when fluid accumulates behind the iris, it pushes the iris forwards and closes the drainage angle. And lastly, you have laser peripheral iridoplasty here, which is where we use laser to essentially cause a constriction of the iris, and that's done in the treatment of plateau iris and also in some cases angle closure. So you can imagine by causing heat there to shrink the iris, you're essentially forming a little pleat in that iris, and it's pulling that iris away from its drainage angle and therefore stopping impediment of the fluid draining out of the eye. Surgery is mainly targeted at trying to reduce the pressure of the eye by allowing a separate pathway for fluid to drain out of the eye. So we have different forms of glaucoma surgery. The form which is most classically performed is trabeculectomy, which is where we create a special trapdoor for fluid to drain out of the eye. Then you have glaucoma drainage tubes, which is where fluid drains through the special tube onto the surface wall of the eye. And then you have cyclodiode, which can also be done in little children. And the idea here is that this probe causes a destruction of the ciliary body, the structure which produces fluid, and essentially reduces the production of aqueous and therefore reduces the pressure in the eye. So the patient might ask you for a second opinion, and that is because the patient is scared of the possibility of going blind. When it comes to the discussion about surgery, we surgeons really take that quite seriously. We would only consider the surgery if the risk of vision loss is greater than the risk of surgery. When it comes to glaucoma surgery, they're not a one-off operation. And in fact, I usually tell my patients it's a 3-month-long operation. 95% of the job is done in theater, but some patients require fine-tuning down the road at the post-operative period, or Patients may lose control of their glaucoma and may require more surgeries or may need to be restarted back on your glaucoma medications. But the risk of surgery is only taken when there is a significant risk of going blind from this condition. And the risk of going blind from the surgery is usually less than 0.1%, and the risk of severe infection, inflammation, or bleeding is less than 1%. Aspects of the post-op which needs to be considered for our patients is that some patients may not be able to drive after the operation, and that decision as to when they should be safe to drive should really be up to the patient and the surgeon to decide on. Certain activities may not be a possibility at the post-operative period. That includes activities like gardening or heavy lifting. And as I've mentioned, the glasses prescription will change, and also patients may need to be on medications up to 3 months after the operation. So if a patient contacts you and is unaware of how long the medications are and what the medication should be, I would encourage that patient to get in touch with the ophthalmologist directly, because we certainly make a lot of changes to the glaucoma medications and also the frequency of the use of the steroids after these glaucoma procedures. Certainly consider referring to a glaucoma specialist if your patient has poor compliance with the medication, because A, if they do not use the medication, they will go blind from this condition. Two, if they have any side effects to their current medication, to allow us the opportunity to change the medications. Three, if you're starting a patient on tricyclic antidepressants or anti-epileptic medications, particularly have narrow drainage angles, as that may influence us to do a laser peripheral iridotomy in this patients a bit sooner, so you can safely start these medications. Next, be aware of the symptoms of acute angle closure glaucoma, because there are cases of patients being misdiagnosed as conjunctivitis or having acute abdomen and going blind from this condition. And lastly, these are chronic conditions. Glaucoma is a chronic condition which requires follow-up. So if a patient does not have regular follow-up, then do write to us, as they could go blind from inadequate follow-up. We also have a very important role in patient education. It's important to educate our patients about the chronic nature of glaucoma. And as arduous as it is important that they stick to their treatment and attend their regular monitoring. Next, inform the patient of acute angle closure glaucoma warning symptoms and to seek immediate attention if this occurs. And third, make sure that patients' family members are also screened for glaucoma. In fact, Glaucoma New Zealand advocates for these patients to be tested from the age of 25 if there is a family history of glaucoma. It is important to consider that for patients, being diagnosed with this condition is really a shock in the system. Patients go through a grieving process, and a lot of times they may discuss it with yourself. So it's important that you're aware of support agencies for patients with glaucoma, including Glaucoma New Zealand, Blind Low Vision New Zealand, and if they have a concurrent condition with as such as macular degeneration, there's also Macular Degeneration New Zealand. So thank you very much for your attention today. And if you have any questions, do drop me an email. Thank you.